Hello, friends. I'll take you through the management of gram-positive organisms, focusing on the clinical importance, diagnosis, and treatment strategies in critical care. So, allow me to share the slides first. Yes, so you all know me. I'm Dr. Bharat, Director of Critical Care Department, Kokilaben Hospital, Navi, Mumbai. And we know both gram-negative and gram-positive organisms are major ICU pathogens, while gram-negative often dominate in Indian scenario, and they're more common in the intra-abdominal infections, VAP, what we see across. But the gram-positive is also building up, and they're mostly seen as key bloodstream, line, and prosthetic-related infections. And the difference in between the cell wall is gram-negative gram-positive has a thick peptidoglycan wall. There's no outer membrane, and gram-negative has thin peptidoglycan layer, but the outer membrane is there which is in form of the lipopolysaccharides. So yes, among gram-positive, what is important is amongst the cocci like Staphylococcus, Streptococcus, Pneumococcus, Enterococcus are most relevant, and among bacilli, Listeria is an important one, especially in immunocompromised host. Common clinical syndromes, that is, the gram-positive cocci, typically causes line infections, skin, soft tissue infections, endocarditis, and pneumonia and UTIs. And we can also see Enterococcus frequently complicating intra-abdominal infections as well. So when you differentiate the Staphylococcus, because this is the most clinically significant gram-positive organism, especially because of MRSA, they are classified as cons, that is coagulous negative, and the coagulous positive. But what is relevant to us is mostly the gram-positive MRSA. And whenever we look here of MRSA, we are always worried about, because the Indian data shows MRSA prevalence around 41% higher in ICU patients, and the most common sites were the skin, bloodstream, and the respiratory tract. It's important to understand what all these terminologies means when there's something called as healthcare associated, that is hospital onset nosocomial infection, which comes in the patient who's been admitted in an ICU, that is IPD patient. There's something called as healthcare associated community onset. So this is a patient where the infections acquired from the healthcare, but they are not an IPD patient. They are the frequent visits to the hospital, like a patient on the hemodialysis, someone on the intravenous antibiotic therapy, or visiting the hospital for the wound care. And also the communicated acquired a complicated infection. Patient has no relation, has not been coming to the hospital. It's a purely infection which is a community acquired. And it's important to distinguish between the two because they differ in the population, affected risk factors, genetic background, and the commonly acquired MRSA is linked to the PVL toxin and often severe skin infections, while hospital-acquired MRSA is linked to devices and prolonged hospital stay. And when it comes to the treatment, commonly acquired MRSA are 95% sensitive to clindamycin in respect to the hospital-acquired MRSA, which is resistant to clindamycin in most of the cases. So risk factors include indwelling lines, prosthetic devices, diabetic patients, nasal colonization. Always look for the metastatic infections, that is bone, joint, CNS, spleen, and often for the stigmata of endocarditis. So looking for the risk factors in such patients and the metastatic ones, also the stigmata of infective endocarditis is very much important. Blood cultures are the gold standard. Even a single positive blood culture for Staph aureus is significant. Cultures should be repeated every 24 to 48 hours until the clearance, until we have the documented negative. So MRSA is defined by the presence of 2065 kp SEC MEC element inserted, and it contains the MEC gene complex, and this leads to change in PVP2. So the quicker ways to identify MRSA is doing the MRSA PCR, BCID channels, or other PCR blood cultures ID panels, and pneumonia panels can rapidly detect the MECK genes, and cefoxitin resistance serves as a good surrogate for MRSA. So whenever the culture report is ready, what specifically we should be looking into it is the oxacillin first, because oxacillin is measured to determine resistance and is used as historically is being used as a primary marker for methicillin resistance. However, oxacillin testing can sometimes give false negative, especially in heteroresistant MRSA, where some subpopulation resistance and other are susceptible. So cefoxitin is now preferred in many labs as a more reliable surrogate for detecting the MECK-mediated resistance. It induces expression of MECK gene more efficiently than oxacillin, making it easier to detect resistance in both the disk diffusion and the MIC testing. And as a result, CLSI recommends cefoxitin disc diffusion or MIC testing for routine MRSA detection. So whenever also we should need to look for the clindamycin, erythromycin, ask for the D test, and especially the D test is a disc diffusion test used to detect inducible clindamycin resistant in bacteria, especially the Staphylococcus aureus. It checks whether bacteria that looks clindamycin sensitivity or routine culture actually have a hidden resistance that could cause treatment failure. So this is what we are looking at. So what D test does is if D test is positive, do not use clindamycin even if culture shows sensitive. If the D test is negative, clindamycin can safely be used. And clindamycin is an excellent drug for the skin and soft tissue infection and MRSA with good oral bioavailability and use it without confirming, do not use it without confirming inducible resistance can result resistance. So as we understood, we also been looking for the revised CLSI guideline where the vancomycin MIC is the key. MIC keep gradual increases over time, and there's something called as vancomycin MIC keep, where there's a gradual increase over time, which has been observed, and outcomes with higher MICs are controversial. But generally, MICs more than two should raise concern for failure and push us towards alternative treatment. And when it comes to the classification of the vancomycin. So we have the break point. So when the vancomycin is susceptible, a MIC should be less than 2 microgram per ml. We call it VISA, that is vancomycin intermediate staph aureus. The MIC would be somewhere around 2 to 8. And when it's vancomycin resistant, VRSA, then MIC is more than 8 microgram per ml and mostly is more than 16 in certain cases as well. So, reduced susceptibility to vancomycin, we always see there's an MIC creep because of the cell wall alteration and plasmid-mediated horizontal gene transfer. And there's also heteroresistance in visa patterns. This is what we have to look into. So, if you look into the MIC, or as far as the vancomycin is concerned, there's very heterogeneous data. We look into this meta-analysis in 2012, which included 22 studies. What it found was patients with MRSA bacteremia who were treated with MIC, who were treated with vancomycin when the MIC is more than 2 in respect to the MIC less than 2. There were increase in the mortality was not observed in cases with MIC less than 1.5. Similarly, in 2016, retrospective study including 170 patients of MRSA, where the vancomycin was used in MICs of 1.5 to 2. Treatment with vancomycin was associated with higher treatment failure and a higher rate of renal complications than the daptomycin. And in 2014, meta-analysis including 30 studies with more than 8,200 episodes of Staph aureus bacteremia found no difference in mortality between patients with isolated high MIC and those with isolated low MICs. Here the cutoff was 1.5. So there has been varied studies concerning, but overall, what we look into is MIC less than more than 2 should raise concern for the failure and push us towards the alternative as well. And when we should be looking for the clinical suspicions for the VRSA, that vancomycin resistant Staph aureus, we have to repeat it isolation from sterile site despite appropriate therapy with source control. We come across metastatic abscesses, or maybe there's a persistent bacteremia, pertinent because of longer the bacteremia, greater the risk of complications. Other test, whenever there's a bacterium to look for the source, we can do the transesophageal echocardiography. CT scan can be done to look for the abdominal or costovertebral tenderness. We can do the MRI to look if the patient has a headache and FND, and PET CT in the selected cases where we don't have the diagnosis. So indication for the TT when there is a persistent Staph aureus bacterium despite appropriate antibacterial therapy, short time to blood culture positivity, unknown duration of bacteremia, presence of cardiac prosthetic material, absence of evident removable source of bacteremia, or the patient is on hemodialysis where the risk of getting infective endocarditis MRSA related is very high, and the intravenous drug abuses. So if we do a TTP, then we have the prediction rules for ruling out endocarditis in patients with Staph aureus bacteremia. So there are very overview of the positive and predictive and VISTA score is what we follow. And when do we think of Staph aureus and pneumonia? So it's Staph aureus and pneumonia is quite common in the Western world, and it's an uncommon cause of pneumonia in India. We don't see it very often. And the risk factors are previous MRSA infection of the colonization. There's a recurrent skin infection, and the patient was hemodialysis. Uh, So when we compare the treatment, when we use vancomycin, so what it goes in favor of vancomycin is time tested, is well studied for bacterium and endocarditis, but we are not sure about the therapeutic concentration. Rising, that is creeping MICs leads to the failure on the treatment, not a greater agent for MSSA, and it's a nephrotoxic and has a poor soft tissue penetration as well. But in comparison with teicoplanin is less nephrotoxic as compared to vancomycin. Efficacy is equally good even in terms of the bacteremia, but it's not a great agent for the CNS infection in the endocarditis patient. But when there was a comparative efficacy and safety analysis of vancomycin versus teicoplanin, systematic review and meta-analysis, teicoplanin was not inferior to vancomycin with regard to efficacy and associated with lower adverse event than the vancomycin. So overall, efficacy of teicoplanin and vancomycin are equally good for treating gram-positive bacterial infection, including the MRSA. Safety is teicoplanin has a distinct safety advantage, especially with the patient with the renal concerns, and it's convenient because teicoplanin is once daily dosing as compared to the vancomycin, which is a frequent dosing. Then when we looked into the treatment of hospital-acquired pneumonia with linezolid or vancomycin systematic review, it analyzed 9 RCTs and more than 4,000 patients are seen. We found similar efficacy between the vancomycin and linezolid when it comes to the HAP patients who had MRSA HAP. But do not use daptomycin in the lung patients. We all know the reasons. Daptomycin, though it's a good drug, it's a bactericidal, has excellent empiric choice. It's approved for the skin and soft tissue infections, bacteremia, right-sided infective endocarditis, and preferred agent when the MIC of vanc is more than 2, but it can't be used for the pneumonia. It's comparatively costly as compared to the vancomycin, and we need to monitor the CPK value weekly when it comes to the daptomycin. Linezolid, again, an excellent drug with good oral bioavailability. Very good option when the vanc MIC is on the higher side, but not approved as an empiric therapy for the bacteremia and not suitable for the prolonged therapy due to cytopenia, neuropathy, thrombocytopenia, and it's a bacteriostatic one as well. So on the auxiliary dynones, we compared the linezolid versus tidazolid. So linezolid is bacteriostatic, and tidazolid is the second generation of auxiliary dynones, and it's also indicated for the soft and skin tissue infections, including MRSA, but not good for the MRSA, indicated for the MRSA bacteremia. And it could be given 200 milligram for 6 days, which showed non-inferior efficacy when compared to the linezolid 600 milligram twice a day. Telavancin, again, FDA approved for the pneumonia and the MRSA infections. Same was true with the delafloxacin. So now the staph aureus with the prosthesis. So we come across this condition, and this is where we've been using rifampicin. So the condition where the patient is susceptible to rifampicin, in case of the prosthesis, rifampicin should be combined with the inhibitory agent, preferably a fluoroquinolone or fusadic acid. Note that rifampicin fluoroquinolone should be considered the first-line regimen for implant-associated infection, and when there's a resistant to or intolerant to rifampicin, fluoroquinolone combination should be used, and whether resistant and intolerant to both rifampicin and fluoroquinolone, then the monotherapy with the inhibitory agents can be used. And staph aureus, in case with processes in case of the infective endocarditis, when the patient is susceptible to the oxacillin susceptible strains, then neficillin or oxacillin along with rifampicin or gentamicin can be used. And while the oxacillin resistant strain, then we can use vancomycin plus rifampicin plus gentamicin. Other key points to consider to look for endocarditis: if there's a community acquired Staphylococcus aureus bacteremia, presence of cardiac device, there's a prolonged bacteremia more than 72 hours in spite of appropriate therapy, and no use of rifampicin. We can't be using rifampicin apart from prosthesis and bone infection, and can consider addition of other beta-lactam ceftaroline in terms of treatment failure. Duration of therapy, this is very important because in skin and soft tissue infection, we need debridement. Duration could be 7 to 14 days. In bacteremia, it could be 14 days. In endocarditis, it has to go on for 6 weeks. And in bone infection, it has to go on for 6 weeks to 12 weeks. So when it comes to the drug-to-drug comparison, so vancomycin is good for bacteremia, osteomyelitis, can be used for the endocarditis, but it has the issues of the creeping MICs that tend to overdose the drug in renal failure. Linezolid is very good for the osteomyelitis, lung and CNS, but is bacteriostatic and has got long-term toxicities. Teicoplanin is good for the Staphylococcus aureus bacteremia has good bone penetration as well, but not good for the endocarditis. Daptomycin is very good for the bacteremia, especially when the vancomycin is more than 2. But again, it can't be used for the lung infection. Tigecycline is good for the skin and soft tissue and intra-abdominal infection, but not good for the bloodstream infection. Ceftaroline, we can use it for the MRSA, pneumonia, infective endocarditis, all the categories, and even in the bone cases. So the treatment regimes for the persistent Staph aureus bacteremia. There are various regimens which has been looked into. So if you look into the Rose trial, that's 2013, where the daptomycin plus rifampicin was used, what they found was clinical success was 83%, but the macrobiological eradication, the time to eradication was not reported. In another study by Dan in 2011, where the daptomycin along with anti-staphylococcal beta-lactam was studied, where the clinical success was 100%, microbiological eradication was 100%, but the time to eradication median was 1 day. Similarly, is seen in the other studies where the daptomycin is also used along with the ceftaroline, and daptomycin is also used with the cotrimoxazole. So combination of vancomycin and beta-lactam for methicillin resistant Staphylococcus aureus bacteremia. So it was a pilot RCT where 60 patients received vancomycin and in comparison with vancomycin plus flucloxacillin. The mean duration of bacteremia was 3 days in standard therapy group compared to 1.94 days in the combination group. So combination therapy with the vancomycin is being used, especially when it reduces the day of the bacteremia, reduces the complication, and especially useful when the bacteremia doesn't clears up. So the different combination therapies what we can be using is the daptomycin plus ceftaroline or other beta-lactams, vancomycin plus ceftaroline or other beta-lactams, daptomycin plus trimethoprene or sulfamethoxazole, and ceftaroline plus trimethoprene or sulfamethoxazole. Now, the key to success in Staph aureus is correct identification. Do not use Vanc or Tico for MSSA unless allergic issues. Do not use quinolones or aminoglycosides alone, even if sensitive. Make sure to rule out metastatic spread before stopping MRSA therapy. Strictly follow infection control guidelines. Then another gram-positive coca, that is Enterococcus faecium. We see this kind of culture report very often, but we also need to be remembered it's part of normal GI flora. It can cause common colonization of GU tract as well and get selected out after extensive cephalosporin treatment. So not indicated in routine infections like appendicitis, cholangitis, or cholecystitis, but add Enterococcus cover in intra-abdominal infection if it's post-op, re-exfoliation, prolonged stay in hospital with exposure to antibiotics. How to interpret for the reports? Look for ampicillin or the penicillin is sensitive, then treat with ampicillin and amoxiclav. Quicker ways to identify MRSA. If resistant, look for linezolid, tigecycline, and daptomycin. Thank you. Grateful for your attention and time. Keep following my channel. We'll keep posting more and more talks for your benefit and sharing the knowledge. Thank you very much.